So I'll quickly go. We'll go. We'll go for a quick brainstorming session for the second one. Μπορώ να έχω τα slides λίγο? So this is about a young lady, 43-year-old lady who 5 years ago underwent mitral valve repair for, sorry, it's not the Barlow mitral valve, it's posterior mitral valve leaflet prolapse. And she had a C-shaped ring and a posterior leaflet plication. Unfortunately, it was unsuccessful as she developed postoperative SAM with severe MR. And even more unfortunately, she had a redo attempt to repair, which actually worsened the result. One could say we could stay here and say, okay, it's a post-operative SAM, it happens. However, things got more interesting with time because a year ago, she presented to us for family screening because there was a new diagnosis of hypertrophic cardiomyopathy in the family. She herself had a clinical diagnosis of HCM, interestingly, with very minor hypertrophy, but that's the phenotype in the family. There's 5, 6 people in the family who have very profound crypts. They do present with abnormal mitral valves, and the oldest one has a maximal wall thickness of 15 millimeters, not explained by anything else. And they are all carriers of this actin VUS, which we are in the process of segregating, but seems to segregate very well in the family. Now, unfortunately, she's now very symptomatic. She's got young kids, and she cannot even play with them. And we started her on beta blockers and disopyramide, but unfortunately, without any significant improvement. This is her ECG. I would say it's difficult to interpret after 2 surgeries, but she's got an LBBB type ECG with Q waves in the anterior wall. Now here you can appreciate that there's massive sum of the anterior mitral valve leaflet. The posterior is plicated, and the whole coaptation is turned anteriorly. She's got severe MR. You can see in the short axis views that in the SAM septal contact area, there's very, very minimal hypertrophy. This is from the long axis. You can see that it may seem like a central jet, but it does tend to be posterior. And this is an off-axis view just to show you how significant the crypts are. She got severe MR by all means. She's got massive E wave. She's got reversal, systolic flow reversal in the pulmonary veins. And although there's a lot of contamination with the MR, the maximum gradient is quite massive, at 140. So the first thing we ask ourselves is this SAM-related MR, or is there another mechanism? Obviously, she had an abnormal valve. It seems to be more SAM-related. There is a secondary jet here at the commissure, but other than that, it seems to be a posterior jet related to SAM. Again, on the TOE, we found significant obstruction with mid-systolic closure of the aortic valve. And this is just trying to find an optimal short axis view. It did confirm that the maximal wall thickness at the SAM septal point, actually this lesion here is a septal, sorry, it's an impact lesion, is there's very minimal hypertrophy. There's not much room to do anything. So traditionally, what the conventional algorithm to treat these patients is to assess if they've got symptoms. If they do have symptoms, put them on beta blockers, add disopyramide, titrate. If they're fine, stay there. If they're not, try verapamil. Or if not, if everything else fails, consider invasive treatment. Now, speaking about invasive treatment, we're talking about alcohol septal ablation or surgical myectomy traditionally. Both have very good results, but always in high volume centers. And speaking of high volume, what we define as high volume is at least 50 myectomies a year and 30 septal ablations a year. That both not entirely free of complications. So both quote perioperative mortality of 1 to 2%, but especially in the case of myectomy in the third surgery in this lady, that would be much higher. And they both require at least a minimum wall thickness in order to operate. So these are not really an option here. We could say we could try verapamil. I'm very much a fan of verapamil, but I do understand that it's got limitations, especially in patients who may have low blood pressure, like this lady here. This is a paper from 1981 that described how some patients, paradoxically, instead of improving with verapamil, developed abnormal hypertension, which worsened their obstruction and led them into pulmonary edema, which could not otherwise be explained. And in this case, with a massive gradient and hypotension, it wouldn't really be a safe option. So we need to assess our alternatives. We could go for a mitral valve replacement, again, accepting the risk of a third surgery. We tried DDD pacing. It was a sort of, I think after medications, the first attempt to control obstruction. We could try novel approaches or novel interventional approaches or novel medical approaches. Now, putting in a mitral valve in a 43-year-old would not be a good option anyway, because it will be her third surgery. But we do know that when you replace the valve, the prognosis is much worse compared to when you repair the valve. We could try pacing her by inducing left bundle branch block. We desynchronize the ventricle, and perhaps we may reduce the gradient. And that's what observational studies have shown. That's what randomized trials have shown, that the gradients do reduce, but it doesn't reflect in improved capacity for the patients. Plus, she's got a relatively short PR interval. You need to have an adequate PR interval to fit an AV delay there, and she's got already an LBBB type ECG. We could try to get creative. The Alfieri stitch has been an additional measure to myectomy in patients with very long leaflets. We did have a few patients of ours having an Alfieri stitch as well, which actually works very well by anchoring the very long leaflet to the posterior leaflet. But that would require a surgery in this lady. At least we can apply an Alfieri stitch perhaps through a catheter, transcatheterly. Now, I think Professor Hadjimiltiades showed this slide earlier, where you can anchor the posterior leaflet, if it's short enough, anchor the anterior leaflet to the posterior leaflet and move the coaptation away from the LVOT. Now here, with mitral clips, with novel methods like that, feasibility is very largely dependent on the operators. Against this approach would be that the posterior leaflet is plicated, so that forms a questionable landing zone for the clip. But some operators may opt to operate that. The pro is at least that the posterior leaflet is short enough to pull the anterior leaflet away. Other options are to implant a valve in the ring, but it's a C-shaped ring, so it wouldn't be an ideal option. Plus, she's got an evolving phenotype. We see that as this patient grows older, her septum might grow thicker as well, and that may result in a narrow LVOT again. Thank God it's 2023. And we do have perhaps an alternative option. Now, MACE inhibitors are novel therapies for HCM. We have quite a lot of data on them. In Europe, mavacamten is approved, and in Greece for now, very recently was approved. And that's why I'll just speak for mavacamten. Mavacamten showed very strong reductions in terms of LVOT gradients, both at post-exercise, at rest, and after Valsalva. And with very, very little cost to ejection fraction, very few patients had to stop the medication because of a drop in ejection fraction. And Valor HCM actually sort of translated these results into a clinical result, where patients who were eligible who fulfilled criteria to have a myectomy or other septal reduction therapies started the medication, and after a few weeks were assessed, and the majority of them no longer fulfilled criteria because they were feeling better, they were in NYJ class, a lesser class in terms of NYJ class, or their gradients were not high enough to justify having surgery. And this result seemed to be sustained in the long term. So our approach is probably to start this patient in mavacamten and then assess our alternative options. So all in all, treating LVOT obstruction is not always straightforward. It's not easy, go ahead, have a surgery, have a septal ablation. We need to have a thorough understanding of the anatomy and the physiology of obstruction. And we need to plan ahead. The surgeon may have to, should have to, or the interventional cardiologist should have to meet before the surgery with the cardiomyopathy specialist, with the imager, assess the anatomy, plan the operation, plan the intervention. There are options, thankfully, but sometimes we need to think out of the box, and hopefully novel therapies may simplify things. So thank you all.
Thank you.
The 56 week of treatment with very good results. So the main question is to Professor McKenna and Franco Cecchi. Is this patient candidate for mavacamten treatment? We put her on disopyramide, with, but he develops some symptoms and discontinued. So he is a candidate for treatment with mavacamten.
Franco, do you want to kick off? This is your topic.
Yeah,
or part of it.
You know, once more, very interesting case, and let me tell you that I mean, of course, you know, in this case, this unfortunate case, because I mean, two operations, you know, with unsuccessful results, you know, is really something that we should point out. But I mean, usually our options in hypertrophic cardiomyopathy so far has been beta blockers plus disopyramide, the beta blockers that are not enough control the out-of-tract obstruction, which, by the way, I don't, you know, it was referred as far as I understand, 140 millimeters of mercury, but I believe, you know, just that this is really mitral insufficiency. I mean, because you really never reach such a high gradients in hypertrophic cardiomyopathy obstructive. And so in this case, this would be our approach. In a few cases, we've used in elderly people above, let's say, 65, 70, which refused surgery. We've used with, you know, very nice success, pacing and additional beta blockers or disopyramide. But in this case, there was already a left bundle branch block, so I wouldn't really use that. And also the age is too young, as far as I remember. So I believe that, you know, in this case, I would try mavacamten. And if, let's see, I don't know, how long, is it available now in Greece? Because to my knowledge, it's only available in Switzerland. It will be available soon in Italy because it's been approved for a compassionate distribution. How is the situation in Greece now?
I think over the last month it's been
It's available now.
Already?
Yeah, she will be a first or second patient to be started on. It's very recently approved.
But is it supported by the national health system, or they have to pay? Because, you know, it's really very, very expensive.
Not paid, no.
No, free.
Free.
Free. Okay, good, very good, Greece. I mean, just as it will be here. So, will you start for a compassionate use, which in Italy at least has been, you know, it's a little bit cumbersome process?
Well, it certainly is here as well. You have to, you know, fill a lot of documents and then sort of justify.
Yeah, and you have to control it every month.
Exactly.
Every month, the first 3 months.
Exactly. Yes. So there is a protocol here. It's not really out on. You cannot buy it on the pharmacy. You have to go through a process, but we hope it will be approved. That was the point of mentioning that she does have HCM, in our opinion. She's got a valid diagnosis. And that means that probably, you know, the myosin actin connections are in excess in comparison to just a mechanical mitral valve SAM. So that probably will be in favor of our application to give the medication.
Professor Nichogeropoulos wants to make a comment.
Very nice presentation once again. I just want to thinking a little bit out of the box. I don't dispute your diagnosis of HOCM, but in some views of the transophageal views, it looked to me as there is a subaortic membrane, and it is not. It's not rare for a surgeon dealing with a mitral valve to miss out the subaortic obstruction, a fixed subaortic obstruction.
Yeah.
So, and in some views with the aliasing flow, you could see that it's just above or beyond the subaortic ridge. It was a membrane. I didn't see it enough to make sure, but I want to make the point that it is essential to make sure you rule out subaortic, a fixed subaortic obstruction, which can happen and can be missed with catastrophic results.
You're absolutely right. There is a ridge. I pointed it out as probably it's the impact lesion because it's quite deep in the ventricle, and it's actually the point where the anterior mitral valve leaflet hits the septum. So we did notice that, but we didn't consider it to be a ridge, but more of an impact lesion from the valve hitting the septum. Could be. Yeah, you're right, absolutely.
What's your opinion?
Well, again, very nice.
Close the table.
Okay, so final comments then. Can't comment on the membrane, yes or no, but for me, the fundamental thing is, why is the patient symptomatic? Is it obstruction? Is it the mitral regurgitation? And I think disopyramide or MAVA, and if you can get MAVA, that's probably better in the context. Reducing the gradient, is that going to improve the patient? And I think it will, because I think this is the obstruction, but that valve, the fundamental mistake is that an operation was performed without a diagnosis. The diagnosis was not mitral valve prolapse, or it was, but why? And they didn't. That was not appreciated.
Well, I think it was the actin that gives you all this funny phenotype.
And then, so the approach now is, I would not. I think there's. I mean, Franco said this as well. I think there's a serious risk to any procedure. This valve has been operated on twice, and doing a clip, doing any procedure, I would be. That's a last resort. And if you've got drugs, diso or disopyramide, but MAVA would be nice to try and see, because if you reduce the gradient, what is going to happen to symptoms, to mitral regurg, to obstruction? My suspicion is they will all improve, but
so next year the follow-up.
Yeah.
Ευχαριστούμε πάρα πολύ. Νομίζω ότι ήταν καλές οι περιπτώσεις που παρουσιάσατε. Θα τα πούμε και αργότερα. Thank you very much for all. You were impressive speakers and presenters. Thank you.